Okay. So welcome to the fifth session of the lung point of care ultrasound course. And today we'll be talking about viral pneumonia, COVID-19, and other issues that decorate the way we do the ultrasound. So we'll talk about best PEEP. We'll talk about fluid. It's not R, it's air. This is a spelling error. Fluid air balance, grading, COVID-19, Meconium aspiration, PPD, malformation, limitation, and reporting system. Now, just to know that the younger the premature baby, the more B lines you'll see than A lines, and the sliding, either it becomes sluggish or is not as active as we see it in older age babies. And I don't know if you guys practice ventilation, but I do what they called best PEEP, and I use best PEEP. For me, the best PEEP is a dynamic PEEP, so it's a range between numbers. So I say the best PEEP for this baby, let's say between 6 and 8, and that's where the registrars and the nurses can play with it. So the best PEEP is when you get away from unsafe zone of ventilation, which is the under ventilation and the over ventilation. And usually I go with the opening pressure of double the PEEP. So if I am less than or more than double, there probably I am not in the best PEEP's position. So my lung ultrasound is the more the lower the PEEP they use, you'll get B dominant profile, and the more A lines you get with high PEEP. When you get the best PEEP, you are in range of A equal B or minor difference between A and B lines. Of course, if you combine it with the inferior vena cava collapsibility, and you see variability of this collapsibility, and you put Doppler of the inferior vena cava, you'll see haphazard, various waves, no rhythmic. So that's normal for when become non-collapsible and always full during systole and diastole, then you're probably getting low PEEP. But if you are collapsed always, you never open, or you open very slightly, especially if the inferior vena cava on coronal view become like an ellipsoid shape, then probably you have high PEEP. Then you can do the aortic Doppler and even mesenteric artery Doppler. And if it's variable, there is event to event variability, probably you are in a best PEEP place. But if the variability become more than 30% between cycle and other, you probably become low. And if it's the variability become less than 30, you probably getting high PEEP. Then you can do EA ratio at the mitral Doppler, and E represent the passive filling of the ventricle, and A represent the atrial contraction or active filling of the left ventricle. If the E and A are equal, remember that the premature baby more depend on E, so always E more than A. In term, usually they are equal, but in adult A more than E. However, if your E is less than A, that means the filling depend on atrial contraction, you probably have high PEEP that impede the preload, the blood coming back to heart. And if your E more than A, of course, you can use the graphics and loops. There are many indications where you are in a safe zone and you are a best PEEP. Any question about best PEEP with the help of ultrasound?
This year is still valid in cases of significant PDA also?
I did not hear you. There is noise background with
the EA ratio.
The EA ratio or AB ratio?
EA, that's the last one.
This is cardiac. This is not our fault.
Does it hold valid even when there is a significant PDA?
Your voice is not clear. I don't understand the question.
But that will is it valid even when there is a significant TDA in the baby?
Oh, that's a different code. This is hemodynamics. Yeah, we're talking about best PEEP. We can talk
Yeah,
about EA ratio for 1 hour. No, we will not. I don't want to answer that. I mean, it's not that within because other will not understand. So that's a different topic. But E and A ratio can be helpful in deciding the best PEEP. Of course, there are other compounding factors, can affect the E and A ratio. There are many, not only the PDA. PDA is a certain pathophysiological process that affect the heart and the peripheral vascular resistance and pulmonary vascular resistance, and it affect everything, all the hemodynamics of the heart. And one of them, yes, it affects EA ratio, but this is out of the scope of this session. So what I'm trying to say is that AB value or A and B profile can be of help in addition to other factors to assess or determine the best PEEP. And in my practice, the best PEEP is dynamic, which means it's a range of number. It's not only one number. So I don't like very low PEEP. So I don't have phobia. And I don't have PEEPophilia. I don't like high PEEP, but I don't like low PEEP. So I always strive to get the best PEEP. Questions about lung ultrasound? Any question? Okay, now we have something called scoring that help not only assessing the severity of the pathology, but also can help you to determine whether you need an intervention or not. So what we do is we do the AB profile zones, and then we can give numbers. So if we see dominantly A lines, we give score of 1. If it's A more than B, but B is present, then it's a score of 2. If both are present, but B more than A, then it's a 3. If the A lines, B lines are become coalescent, and there is no A lines, we give a score of 4. And the score of 4 also, you might see from some fluid, sometimes air bronchogram. So it's very important to see score A, score B, score 3, score 4. However, you'll see some literature, they score 0 to 3. So be careful which zone you use, which reporting system or grading use. So if you have more A lines, that means you have more air. So it's either you are giving more air. Now, considering that the sliding is positive. So if the sliding is not positive, it is a different issue. So if A lines is more, then you are dealing either there is no fluid making the A lines high, or there is more air causing the A lines. So usually the normal lung architecture is you have a mix of both. So what do you have? You have A lines, not very frequent. The A lines fade away once you get away from the probe, and they are interfaced with B lines, and B lines are easily differentiated from pleura. There is nice sliding, and these B lines are separated and they don't reach to the end of image. Once the B lines become more, so either you have more fluid, such as edema or interstitial edema, or your PEEP becoming less, you are underventilated, and that's why you get less A lines and more B lines. Any question about scoring? Okay, so grading, as we've talked, so you have A lines that fade away. They are very separated. You have B lines that does not reach to the end, and you can easily differentiate pleura from the B lines. With grade 2, you will get more B lines, and it's not easy to differentiate from the pleura. You get some A lines. In grade 3, most of your A lines disappear, and B lines become matted, and you might have some fluid. In grade 4 is completely matted, but sometimes you'll see some fluid and air bronchogram. Clear? Questions? Okay, And now we go to the scoring. So we get the grade and we get the scoring. Now, sometimes you cannot get all the pictures. So you have to make a decision on the pictures or the zones that you already. So you have right side and we have left side. And we have 6 zones on the right and 6 zones on the left. Each zone is scored from 1 to 4. So you can do the right side scoring and you get 24, or you can get left side scoring and you get 24. Or you can scoring of the upper and the lower, or scoring of the lateral and scoring of the upper lateral, lower lateral, posterior upper, posterior lower, whatever. So you can also get scoring of either side on both sides on one zone. So and then the score here range from 2 to 8. You can get total score of the side scores or of the zone scores, and the total is 48. So the lower score of the total is 12 to 48. Now, minimum score of 12 mean either you are dehydrated or overventilated, and maximum score of 48, you have either edema or you are under inflation. Questions? Yes, sir.
So it's all clear this, but I was looking at 3 and 4. The picture in 3 and 4 are sort of the same to me, apart from the pleura. In 4, there is some bronchogram and it's
No,
more.
they are not actually the same, doctor. You can see the B lines are sometimes separated, and you can see that the pleura is still there a little bit. But here you'll see that the invasion become more and it's completely matted. But sometimes I agree with you, you can say it's a 3 to 4. You can't have a clear definition. But once you do more, it will be more clear. Yeah. But I sort of agree with you. They are almost close to each other, but you'll always will find easy to find 4 and easy to find 3. Sometimes you cannot, so you can see it's somewhere between a 3 to 4.
Excuse me, doctor.
Yes, ma'am.
So normal lung will be grade 0.
There is no grade 0. There is some reporting system. They use 0 to 3, but I use the scoring 1 to 4.
So normal lung will be grade 1.
That's one zone.
If
one
we
zone,
see a normal lung at any part,
it's a score 1, yes. If it's all, it's a score 12. If it's one side, it's a score 6. If
so
it's
what you showed in the previous slide, so 1 is the A lines is normal lung. The number 1.
This is grading, ma'am. There is no normal here. So you have a grade 1 to grade 4. There is no normal and abnormal. This is a grading. So you just say grade 1. You don't say a normal line. But once you see A lines or B lines or even B lines, it's a normally structured lung. There is no loss of architecture of the lung.
When we are doing a scan in, like, suppose the zones R1, R2, R3, when we don't find an abnormality and we feel it's a normal lung, what score should we give?
Well, first, you should not do scan without a history. You are doing the scan for something else. For you want to confirm or exclude something. Okay, so we don't say normal lung without a clinical. So you do not go and do ultrasound for baby who's breathing, no, unless you want to show people what is normal lung. But usually we do not do ultrasound just for fun and on a normal lung, and then you get very rarely you'll get normal lung. You always do the lung ultrasound for a reason. So you can say there is no abnormal finding. You can say the score is this. And you can say that. We will show you how to report.
Okay.
More questions?
Yes, when Dr. Yaya, but sometimes baby came with respiratory distress. We suspect TT and maybe meconium aspiration. We found a normal X-ray. It's possible that X-ray is totally normal, even there are some symptoms is there.
In 70% of situations, the X-ray is normal and the finding on ultrasound is there. I will show you cases.
Okay.
Yeah, it more than 70% of cases, and I've sent the sensitivity and specificity because Dr. Shadid asked me for, and I sent him, and he has the numbers. This is with evidence. What is the sensitivity and specificity for each pathology between lung and lung ultrasound and X-ray compared to the gold standard, which is the CT scan? More questions? Okay, so what these numbers means? Well, it means the severity, mild, moderate, or severe. So if one zone you're doing, and if you see score 1, then it's a mild problem, or as the doctor was saying, normal. If it's moderate, it's 2 to 3. If it's severe, then it's 4. If you're doing zone on both sides, so for example, R1, L1, then the normal is, or the mild is 1 to 3, while the moderate is 4 to 6, or severe is 7 to 8. Now, if you're doing only right side or left side, then the mild is 6 to 8, while the moderate is 12 to 18, and the severe is 19 to 24. If you're scoring the whole, then the mild 12 to 23, the moderate 24 to 36, and the severe 37 to 48. What does that mild and moderate mean? Mild. The intervention is not indicated. Diagnosis is unlikely. So now I'm going to answer Dr. Shadid questions. He asked me maybe a few hours ago, what about surfactant? Well, here's the question. Mild, you don't need. It's very, intervention is not indicated and diagnosis is unlikely. If it's moderate, the intervention may be indicated, the diagnosis is possible. Now, if it's severe, the intervention is indicated and the diagnosis is likely. Dr. Shadid?
Yes, it is clear. It's clear. Thank you.
Yeah. Any more questions, please? Okay, so let's go to COVID-19. Now, in COVID-19, we know the virus preferred the ischemic area. So they go to the posterior part of the inferior part of the lung. According to the literature that I collect these symptoms from, one of the most important is multifocal B line that is discrete or confluent, or it's a B profile. And usually this appears in early stages. And once the patients start to recover, you'll see more A lines. You'll see pleural thickening, and you might see interrupted pleura or C profile. You might see subpleural consolidation, also known as skip lesions, or C profile. You can see air program, again, it's a C profile. You can see localized consolidation, or sometimes you see transloper consolidation, which is very unlikely in usual pneumonia. But also you can see non-transloper consolidation. You can see localized thickening, I mean, loss of architecture of the lung, loss of B and A lines. You might see edema with sometime pleural effusion. And local thickening with edema and pleural effusion, it reflects in the CT scan as what we call it crazy pavement pattern. You may see pleural effusion, although it's very rare. It's usually fluid deprived. You'll see insufficient blood supply because it's an ischemic lesion. Usually, if you want to diagnose, the lesion are very superficial, and I think you prefer the linear probe to see the pleural pathology and also subpleural problem. You can use the curvilinear for deep pathology, especially if you're looking to the hilum and also you're looking the lesion near the diaphragm. So this is a CT scan, and this is the lung ultrasound. So you can see that there is separate B lines, and you can see the pleura are interrupted. This is the posterior or R5 or L5. So in this situation, it's R5. Now, when you get more severe, you get more loss of pleura, and you get the pleura irregular, or what we call it lumpy, pumpy. It looks like exact pattern of pulmonary hemorrhage. And you'll see that the B lines are become confluent or grade 3 to 4 in the grading system. And you'll see that you're losing the B lines. Now we get more severe, you might get what we call it strip sign of pleura or C profile. You can see the pleura are separated, and not only that, you get like onion shaped pleura. Now you get more severe, you get thick pleura, you lose the pleura and you start to see air bronchogram. And if you put Doppler, you'll see an ischemic lesion. There is no Doppler inside it. And you can see also a C profile without Doppler, and you might see just increasing B lines. And this is the lesion depending on the location. So you can see it's more severe on the posterior and less severe on the interior, and it's more severe in R5, R6, R4, and R6, L4, and L6. Any question? Any comment or any question? Questions? Okay. Now let's move to the meconium aspiration syndrome. Meconium aspiration syndrome, there are many things that distinguish the syndrome. First, we have poop and protein and fluid inside the alveoli that it neutralizes the alveoli, the surfactant. So you get atelectasis. Second, it's a foreign material, so it causes pneumonitis. And third, it is a blogging agent, so it causes collapses, but it might cause ball valve and it causes a pneumothorax. Pneumothorax is a disease of space change. So it's a course or it's an irregular pathology. So it mix of normal lung or grade 1 to grade 4. So you see grade 1, then you can see grade 4, and so on. You can see coalescent or sparse alveoli. You can see interstitial pattern or consolidation, sometimes with air bronchogram. Irregularity present all over the lung and may change from time to time because the meconium is associated with inflammatory process, and they change the course of disease. You might see a meconium plug and lead to atelectasis. So here is a baby with, here is the X-ray, and here is the lung finding. So you can see a little bit of normal pleura with B lines, and there is A lines. You probably can say this is normal, but then anyhow, you lose the lung architecture. You can see fluid, you can see air bronchogram. You suspect this is consolidation. You lose the pleura continuity, and then become back normal pleura. And you can see, so normal, and same here, you can see abnormal like pneumonia with C profile and air bronchogram and fluid with interruption of pleura, and all of a sudden you see the pleura and you can see the B lines with some A lines. Of course, you will see the baby in a history, with a history of, most of pneumonia, either lobar or translobar. They don't go like in this diffuse pattern, normal, abnormal, normal, abnormal. So either you see a local area of normality so that you can differentiate pneumonia. You can also differentiate from pulmonary hemorrhage, as we will see later and when we discuss cases. Questions? Any question? Allahu Akbar. No question?
So the only way, doctor, to differentiate is the history, actually, because now for me, without history, I will only describe this lesion.
No, so when you do meconium aspiration, first it is a diffuse pattern. It affects all the body. It does not affect a local area like pneumonia. That's one. Second, pneumonia, it can be lobar or it can be translobar. So everything involved or allocation only. You will never see normal, abnormal, normal, abnormal, because the meconium is a disease of change and it includes all the lung. That's how you differentiate. So you can see abnormal, normal, or at least grade 5, grade 4, and grade 1, grade 4, and grade 1. So pneumonia either localized or translobar. If it's translobar, it's a you'll never see normal. And if it's lobar, you'll see a normal area and the rest are normal. Then you will not see another abnormal. That's usually how you differentiate, especially if the lesion cross the ribs. So between the ribs, you have normal, abnormal, normal, abnormal, and so on. And of course, the history will help you. Absolutely.
Okay, doctor, thank you.
More questions, please.
Dr. Yahya, Dr.
Yes,
Yahya, if I do Doppler in this area, do you think that the Doppler, it will help that it will be hyperemic, or do you think it will be more?
It won't give you any clue. It won't give you any clue because this is not inflammatory process. A little part of it inflammatory, but most of it is pneumonitis, neutralization of the surfactant, blogging and collapse, or blogging on ball valve. So there are various pathologies that cause the pneumothorax, not only the inflammation. You might find some hyperemia, and you might find ischemia. Either way, it won't help you.
My second question, Dr. Yahya, do you think that, or what do you think that in each ultrasound, we have to do the Doppler and M mode? Because the M mode, it will help you regarding the pleural effusions, and the Doppler, it will help you regarding if it's bacteria or viral. What's your advice on that?
You can do that. I mean, if you're not busy and the baby is stable, you can do whatever you like. But usually in ultrasound, I take 5 minutes to do it, maybe less. So if you do everything, you might get 10 minutes, 20 minutes. Yeah, you can do that. I mean, for learning process, you can do that. But with time, you'll have a specific question to answer. So when you get your answer, you don't need to continue. So that's usually what I do. Some of the baby I cannot do the bag, so not all of the baby I do Doppler, unless I have a question. This is a vascular region for arteriovenous malformation. I do Doppler. If it's a viral or bacterial pneumonia, I do Doppler. Otherwise, in the lung, Doppler will not help. M mode, if you have fluid and you need to measure it, yes, yeah, you can do M mode, absolutely. M mode will help you in the pleural fusion, and also if you suspect pneumothorax. More questions? Okay, now we will go to bronchopulmonary dysplasia. Now, as you know, the bronchopulmonary dysplasia are of two types, the old and the new. The old, which is the respiratory impalement, and because of the advance of care, we start to see a new one, which is mainly vascular. So when we are talking about bronchopulmonary dysplasia, we are talking about the old bronchopulmonary dysplasia, or the involvement of the lung. If you want to diagnose the new or the end, then you need to do the looking at the pulmonary valve and look dooming, thickening, and measure the pulmonary acceleration time, and then you get the ratio from whole cardiac cycle, and if it's less than 20% or 20 to 30 or more than 30, give you severity of pulmonary hypertension and give you an idea is it about it. And because at that age, the tricuspid gauge might not work, and also the PDA is closed, so you have only one way to measure the pulmonary pressure. So we're talking here about the old or the bronchopulmonary dysplasia that involve the lung tissue. So you'll see non-homogeneous pleural line abnormality. It will looks like more or like meconium aspiration. However, it is an old baby already on ventilator, 1 month, maybe 36 weeks, 32 weeks, an old baby. So you'll see also pleural line thickening and irregularity. You'll see small subpleural and large consolidation. You may see alveolar interstitial pattern in case when the parenchyma involved. You can see atelectasis. You might see bacterial infection, and you might see loss of aeration, and you might see air bronchogram. So this is an example of bronchopulmonary dysplasia. So if you want to describe the bronchopulmonary dysplasia in one word, it will be that I will see all what I learned in lung ultrasound in one image. So that is bronchopulmonary dysplasia. You see everything in one film, in one zone or two zones. So you can see here, pleura is clear. You can see that the pleura is easily separated from B lines. You can see that the B lines fade away once they go away. You can see that the B line are interfaced with the A lines, and also A lines fade away when you go further. So it looks like a pretty normal lung. Once it becomes more severe, you start to see interstitial edema. So you start to see more B lines reaching to the end, less A lines, and you start to have difficulty differentiating B lines start from pleura, and the pleura become a little bit thick. Once you get more severe, you get very wide B lines. Still, they are separated. You will not see where is the pleura starting, so subpulmonary consolidation. Once you get more severe, you'll see loss of continuity of pleura. You might see very tiny air bronchogram reflecting fibrosis. Not very clear borders, but you can see B lines are surrounding. Another example of chronic lung disease, severe one. So you can see that you might have something like pneumonia with B lines around it. You'll see air bronchogram. You can see B lines are wide, matted, reaching to the end, and you can see are losing the pleura. You can see more severe as the lesions goes below, but it's something telling you I am not pneumonia, because it's not localized shredded sign, it's everywhere. And you can see the B lines are inside it. So still there is B lines. This is still lung tissue, but it's abnormal. So you can see even the B lines are inside the lesions, but they are different contrast here. That's mean there is a little bit of fibrosis here. There is more fluid here. There is air bronchogram, losing the pleura. And you can see the B lines are starting haphazardly in different planes. And this is the chest X-ray of the same baby. If you can see, it's very hard to say what is it. And of course, it's more clear in the CT scan. So another type, so you can see this is the chest X-ray, and this is the lesion. So you can see, looks like pneumonia, but it's something telling me it's not pneumonia. Not very demarcated age, less air bronchogram inside it. Still there is some pleura. And if you can see the B line still going inside, and even here, they're reaching here and here. You can see there's some fluid, air bronchogram, B lines are reaching to the end, and you can see continuation of pleura. Become more severe. You can see this. Almost same, but it's more like more deep, more wider. And you can see it's abnormal, then normal, abnormal, then normal. Anyhow, you'll see all the grade within one lung ultrasound. And of course, the history will help you. Again, you can see the X-ray not very much reflecting, while it's very clear in the lung ultrasound, normal area, abnormal area. Even if it's abnormal, but still the B lines go inside it. There is air bronchogram, loss of the pleura, C profile here. Here is more like grade 2 or even 3. You can see that there is a pleura, but it's hard to differentiate from the B lines. There is a little bit of pleural effusion. And again, you can see, although there is pathology, but still the B lines go. So it's like not pneumonia. Some area that you can see the pleura, other area you don't see. You can see the B lines are starting in a different planes. And sometimes you can see A lines, but mostly you'll see fluid and air bronchogram. Now finish with the bronchopulmonary dysplasia And let's look at the pulmonary hemorrhage. So you can see in pulmonary hemorrhage, you will have interfaces between abnormal lung, but it's more as if it's filled with air bronchogram. The air bronchogram are very obvious. Look at the air bronchogram here and look at the air bronchogram here. So you can see around the heart, but also you can see near the pleura. It's very hard to see where is the pleura. There is pulmonary edema, interstitial edema, and these air bronchogram going everywhere. And there is no boundary of these air bronchogram. They are everywhere. Questions?
Dr. Yahya, can I ask about the bronchopulmonary dysplasia?
Yes, please do.
Yeah, if I will check the chest X-ray, I can see like as if there is a collapse in the right upper lobe.
Yes,
If
there is
I will
collapse.
compare it with the,
Yeah, there is collapse.
but this will
definitely.
it's correspond to the what I'm saying.
No, this is an example. I didn't
No,
show you the 12.
cat
The
for
12
ultrasound.
Well, this is not 12 zones. Here's you'll see a global view. Here is you are seeing local view. So yeah, there is possibly there is collapse, and you'll see it very obvious on the lung ultrasound. Yeah, it's very obvious. It's very easy to see that you're losing the lung architecture. Any more questions? No? Okay, malformation. We have the CPAM, which is a large microcystic lesion or irregular consolidation, and there are 4 types. And remember, once you suspect malformation, you have to do CT scan, both X-ray and lung ultrasound, especially lung, are not good for malformation. Now, what is the limitation of lung ultrasound? Now, in this picture, and in this picture, and in this picture, you can see that we are losing the pleura, or it's barely to see the pleura here, but with some fluid. You can see that we're losing the B lines and A lines. Same here. You can see that we are losing A lines or B lines. This is more like chronic lung disease or pneumonia, or it can be also meconium aspiration. But this one is definitely is not an infection because there is no boundaries. The air bronchogram going deeper with obvious B line starting inside and outside. So this is more like pulmonary hemorrhage, but sometimes it's very difficult. In this situation, it can be pulmonary hemorrhage, but it also can be fluid. So in short, that lung ultrasound cannot tell you this is pneumonia, this is atelectasis, or this is hemorrhage. It can tell you that you are losing the architecture of the lung. What you are seeing here is probably not lung because you are not seeing the B lines and A lines, and you don't see the pleura continuity or sliding. And then within the shape of what you're seeing and the context of the case, you can make your differential diagnosis, or you can approve, or you can exclude a certain pathology that is in your mind. Very important to differentiate between subpleural and subpulmonic consolidation. So subpleural consolidation is a fluid below the pleura. Subpulmonic consolidation is difficulty to differentiate B lines from the pleura. Questions? Any question?
So when we can't differentiate the B line from the pleura, why is it not called subpleural?
It's subpulmonic. It's subpulmonic consolidation. This is called subpleural consolidation. There is no science behind it. It's just a name.
Okay.
There is no science behind it. Okay, grading, if you guys remember, very important to remember. grade 1, grade 2, grade 3, grade 4. And as Dr. Shahid was saying sometime, you will have difficulty to differentiate grade 3 from grade 4.
Also in grade 2, it seems to me like we called it here A more than B, but I see like 1, 2, 3, 4, 3B and maybe 4B. The three of them are going down to the end, only one A. So I don't know why did we call it A more than B in number 2.
No, it's B more than A.
That's number 2, B more than A?
Yes.
Okay, then I agree.
And here A more than B.
Okay, okay.
And here matted, but a little bit, still you can see the pleura. While
Yes.
here matted, but you cannot see the pleura, and pleura become more thick and you have more abundant air bronchogram. Clear? Question? Okay, now how we report? How we report? So first and at most, we need a history. Without history, it will be hard and difficult. And I would say 70 to 80% you will be wrong. And remember, you need only one report for people to lose trust in you. So do not report without history and clinical scenario. Second, try to do as much zones as you can do, as was Dr. Sahar asking, why we don't see the collapse, because we don't have full profile. And ultrasound is a local tool. It's not a global tool like CT scan and X-ray. So you only see one window, and to reconstruct the picture in your brain, you need from all sides. So the more sides you take, the better. So you need to history, you need to know your grading, and you need to know your locations. Very important to do your locations. So once you finish your grading and your location, you need to organize it and do the 6 zones on each side. So these are the naming R1 or L1 and so on. So you need to name it. Most of time when you do number 1, 2, 3, 5, and 6, the best way to do it by linear high frequency probe. While those near the diaphragm, you can use the curvilinear and less frequency to see more deep. And if you suspect hilar pathology, you probably need to use curvilinear. Use M mode when you suspect pneumothorax, and this is an answer for Dr. Amna. You can use you can use also the M mode to see the sinusoidal sign to measure the fluid. You also always comment whether there is B lines or air lines, whether the pleura is smooth or not smooth, thickened or irregular, interrupted or not. You can see pleural effusion or not. Whether you will see the shredded sign or the wedge shape with the air bronchogram. You can see penetration signs such as vertebral sign or mirror image or track sign. That's all our penetration sign. Then you need to put your provisional non-official diagnosis, and then somebody supervising you until you achieve your target, give you the final diagnosis. You always need to sign it and date it. Question? Okay, and I'm done with this session. Okay, so you guys, are you tired or you want to see a case?
Oh, I'm very happy to see a case, unless other colleagues are tired.
Any question? Or you guys tired or you want to see case?
Anyone want to see case will second me?
To see cases if possible.
The others are neutrals? Yes, no? We have
Yes.
2 only. 3? 3?
Yes.
4?
Yes, doctor.
5?
5 out of 8 or 9 is good enough.
Okay, so let's see a case. So cases, this one, let's see this one. Yes. Okay, so for neonatologists, Dr. Faris, I talked with you about this. We are here not neonatologists. So I'll give you the history, but this is my practice. So you might practice neonatology in a different way. You might have different opinion. You might don't like the way I do things. You always welcome to comment. But remember, here you are doing lung ultrasound course. So the purpose of giving you the history to give you like the natural process, the normal scenario, and then we do the ultrasound. So if the way I do things, I practice neonatology different from you, you can always send me a text message that you do it in a different way. Deal?
So, go.
Okay. So when I present, I like very detailed. So we have a twin 2, 26 week at birth, day 2 of life now, corrected 26 plus 2, birth weight is 0.869, working weight is 0.9. Current weight on day 2 is not checked because of we practice IVH bundle. The Apgar score is 5, 7, and 9. So mother details are huge, many. I've put all the mother details here. But in short, is a premature baby and she has antenatal bleeding and they are dichorionic, diamniotic. And the Doppler was okay. The fluid was okay also. And she did not receive antenatal steroid and she came with bleeding for a few hours. So we didn't know the status of the baby. They were able to give 1 dose of surfactant of the antenatal steroid 3 hours prior delivery, which we didn't help. And she did not receive magnesium sulfate. Otherwise, she has no GPS screening because she is 26 and all her serology is okay. She has 1 baby, 1 child. He's now 4 years old. There is no signs of choriomyelitis. There is no pain. There's no tenderness, no fever, no leukocytosis. Any question about mother history? Okay. On resuscitation, the baby delivered in a very good condition, and it was cephalic presentation by CS. We did the delay cord clamping for 55 seconds, and we stopped because of the bleeding of the mother. Baby connected right away to CPAP using TPs at the age of about 2 minutes. Breathing was okay, and the heart rate picked up to more than 100. Then we inserted a PICC line, was successful after 1 trial at 10 minutes. The dextrose hit the baby by age of 12 minutes, and the caffeine started at the age of 19 minutes. And then the baby was transferred to an ICU using PPV. At an ICU, we put the baby on again on CPAP, connect to the cardiorespiratory monitor and SAT monitor, intubated at around 11. That's what, about 1 hour, 24 minutes because of increased work of breathing and we need more FiO2. We gave the baby RSI, and then we gave the baby surfactant and connect the baby to SIMV with VG, although the VG failed after 1 minute. So it's active. He received fentanyl and then stopped because of the hypotension developed baby. He's on IVH bundle, humidity and temperature control. So on respiratory, we started mechanical ventilation, SIMV plus VG, PEEP of 6, PIP 21, then 3 point, start with VG of 3.5, then 4, then we fail. So we moved to straight SIMV, always on room air, saturation 95 to 100. So again, here we remove the VG, as I said earlier, and then we wean the SIMV. On the second day, baby developed pulmonary hemorrhage, so switch to PCAC with rate of 60 and receive intratracheal adrenaline and so on. So this is the X-ray. Anybody wanted to comment on the X-ray? can see that the ETT in a good position, the inflation on both sides are okay, the spaces between the ribs are okay, the numbers are 8, they are symmetrical. The respiratory cardiac siloe looks okay. The costophrenic angle also looks okay. There is no crowding of the rib on one side, so inflation are okay. There is no feeding tube, that's a mistake. And the UAC is in a good, in acceptable position, although be high. The UVC is not a good position, so probably need to be pulled or do something. Any question about the X-ray? And the cardiovascular, the baby, a little bit of hypotension. So we stopped the fentanyl, we stopped the VG. We gave normal saline on extended period, half dose because of the IVH bundle, dopamine 5 mic. There is UVC, and there is UAC. GIT, TFI 80, second day increased to 100. The sugar intake was about 2.5 gram per kg per day. We started MEF, working weight 0.9, not past meconium. Potassium also high. Sodium is a borderline. Abnormal renal function. The glucose infusion rate 2.2 milligram per kg per minute, not per day. This is a mistake. The potassium is on the higher side. Infection, he is on ampicillin and gentamicin, then switched to meropenem vancomycin when developed pulmonary hemorrhage. Also echo showed PDA, so we started paracetamol infusion over 3 hours. Baby also received backed RBC and fresh frozen plasma and vitamin K. Blood culture is negative. So, anybody want to comment? R1. Guys.
I can comment.
Yes, please.
So we can see here a thickened pleura.
Yes.
We have a B line. It's a more of a B profile, but there is A line. So I see B lines separated from each other by more than 7 millimeter, many of them, if I can say. And the B line is not separated clearly from the pleura. Yes. So if I will score this, I will score it 2.
Yes, but remember, if you remember the spectrum that we saw, the more you are younger as a gestation, the more B lines abundant. You remember that?
Yes.
And this baby is 26 weeks, right?
Yes.
But I agree with you. There is here either a probe or a plaster or something here making some shadow here. Okay,
but do you agree that's a score 2?
I would say 3, but if you said 2, that's okay.
Because I see one A line here on top.
Yes, yeah, I agree with you. I mean, I'm not arguing, but I would score it 3. But
A lines.
But scoring 2 is okay. Yeah, you can say 2. There is no issues with that. Okay. So what about R2? Anybody want to comment?
Again, we can see a thickened pleural,
and we can
differentiate. Yes, and we cannot differentiate the lower pleura from the B lines. Yes. So we can comment that it's
subpulmonary consolidation.
Consolidations, yes, and you can see that very dense B lines like water. Yes.
You can see that. Still, there is sliding, but because of prematurity, sliding is more like sluggish. But what about here? Do you see the diaphragm is not moving at all? A little bit, not moving very, very little. You can see the B lines, and also the diaphragm are thickened, and there is some air bronchograms. Even here, there is a little bit of air bronchogram. At that time, the baby was asymptomatic when we did that. Okay, so let's do R3. And you can see very small babies, sometimes zones are difficult to differentiate, especially if you have MyProp, which is a little bit bigger size, not specific for no. I don't have the hockey stick right now. Anybody want to comment? We don't hear you.
Dr. Zach has having problem from India. Would you
Maybe
like
I
to
don't know. My
explain that?
laptop has poor mic. I'm not sure. I'm using my laptop. That's why the reason. Maybe. Is it clear now or not? Otherwise, I will hand over to someone.
It's going and coming.
Okay, maybe I'll hand over to someone else. Fine. Bye.
Is Dr. Dumi there? So
Anybody?
here,
Or you want me to? You want
here
me to
we
speak?
see we see a thickened pleura and
Very thickened
larvae
pleura,
lines
yes.
separated from each other, but very thickened, and the separation is less than 7 millimeter. We have also one A line. We see the diaphragm at times, but not really moving.
Yeah, you see
And
this
there is
area?
here consolidation, like there is air bronchogram somewhere.
There is air bronchogram, so I won't call it consolidation because there is no clear boundary.
Yes, yes.
But I
no-
agree there is something replacing the. Yeah, and there is one A lines as you said, and okay. What about here? Now the pathology here is more clear, right? You see this area? You see the diaphragm?
Can we call this one is pulmonary hemorrhage?
It's hard to say pulmonary hemorrhage, but we know, I would say it's not a consolidation, and you can see there is no pleural effusion. Pleura is moving, sliding, and there is more B lines, loss of A lines. We don't know where is the pleura, but I agree there is lots of air bronchogram without boundaries, and you can see here also thickened diaphragm without boundaries. So yeah, possibility of pulmonary hemorrhage is there, but it's very hard to say. Let's go to L1. So you can see that the pleura are already gone, more B lines, and you can see that here is a little bit thickening. So you have various thickness of the pleura, no B lines, pulmonary and interstitial edema. In L2, same almost L1, no much difference, just B lines matted and difficult to see the pleura. In L3, the pathology is more clear. You can see that there is coarse area, the pleura become thick, B lines are very abundant, no A lines. And in L4, again, the pleura is very sluggish. I cannot see the diaphragm. Pleura are thickened, but there is sliding, and we're not very clear consolidation. Now, we couldn't do the bag because the baby is sick, and we cannot do the L and R sick 5 and 6. So at this point from the history, and what is your differential diagnosis or diagnosis?
We have here a baby who is preterm 26 weeks, so likely to have RDS prematurity. Also,
So you can RDS
had pulmonary
prematurity.
hemorrhage. So pulmonary hemorrhage could be caused by sepsis. So one could look in the picture for possible sepsis, and I know you don't like inflammatory markers, but we can look at the ultrasound for inflammatory markers. He had antenatal steroids and magnesium sulfate. I don't know, did he have anyway? So
No, he did not have, and he received only 1 dose of steroid 3 hours because he came in emergency C-section. So she has 1 dose 3 hours prior to the section, and she was no time to give her the magnesium sulfate.
All right.
So 1 day later, 1 day later, the baby developed desaturate while on SIMV, and you have fresh blood coming from ETT. So we increased the PEEP, we switched to PC, AC, and we gave adrenaline and plasma and vitamin K. We switched to high frequency. We've changed the antibiotics. We asked for bleeding profile. We stopped the lipid. We stopped the TBN and switched to D10 with electrolyte because the TBN has some heparin because it's central. And then we repeated the ultrasound. So this is L1.
Okay, so L1 is exactly, we can see that the pleura, it's,
You
we
see the
cannot,
heart? You see the
and the
heart?
heart, yes, and
You see the lung around it?
yes,
Yeah, you see that? You see how obvious now?
yes, very obvious.
Severe pulmonary hemorrhage now.
Yes, you see how obvious and easy? And the reason why it's obvious, because it's not pneumonia. There is no clear boundary. It's more air bronchogram than fluid. And it's very echogenic, okay? And it's clear here. And as if somebody is increasing the echogenicity of ultrasound. However, if you go here, it's only pulmonary edema. There is no. So it's only these areas who have this echogenicity. So again, it's very interesting. So I repeated the L1 again, and it's now very, super clear behind the heart. You can see L1, L2, now super clear below the heart and at the diaphragm. Clear?
Yes,
If we go to L4, no, I don't know what is L3. I don't know, maybe lost it. But again, now is more clear. You can see R1 less, but still there is bleeding, but less than the other zone. And if we go to R2, it's very clear here and here now, less on the left side and on the right side. R2, R3, super clear now. It's like a sliding positive, and these dots are everywhere. R4, and again, very clear now. And I'm done with the case. So
Thank
this is
you
a
very
real
much.
case. This is a real case. That's like, it's not. So I have lots of these cases, inshallah. We will show you a few cases, but this time, as we decided with Dr. Shadid, it will be assignment. So I wish that I will make video and send you the link. And then I'm expecting, once you see video, I'm expecting you to reply and send the report within 10 minutes. If you fail to send it within 10 minutes, then it's a failure.
Let
So
me
you want,
explain to them.
so
if you
you
don't mind.
won't have time to read and ask other people. And the reason is because we want to assess you. So you have to reply within 10 minutes. So it's a time sensitive test. So I'll send you the link. I will wait the reply. I will give you 10 minutes. If no reply, and the reply has to be in the reporting system. So you have to read and type. Okay, you can type on one hand. So you need to be ready. You have your computer. I can send it to you as a PDF. I can send it to you as a Word, whatever you prefer. But you will have 10 minutes too. And if it's 11, it's considered failure.
If you allow me, because I didn't put my colleagues in the context of this, certainly this doesn't, in my opinion, include the radiologist. We learn from them more than, but I wanted to benefit from the Dr. Yahya's experience and also make a publication that's really missing in the literature, which is how many times we need to learn lung ultrasound, because now they say 25 you do with supervision and another 25, but there is a way called the QSUM chart. So maybe next week at in our meeting, I'll explain to you about the study. It will be a study, and then those who would like to enter the study, I will ask their permission by signing a document, because I will have to have your permission to do that study. So I will introduce the study to you next week, and then maybe this way you would benefit as you go. And there is not a question of like nobody is failing anyone. It's just because for the QSUM chart, if I want to apply it, which I will explain to you next week, I need 0 for pass and 1 for not pass. Even if you do beautiful, but I have no choice for the statistical method, it has to be either 0 or 1. So I have no choice between 0 and 1. Even if you know a lot, we have to make a cut, yes or no. And then because it's a study, we have to make it 10 minutes. So we have to have all equal and all not, even if you have time to go to literature, I would ask you to please not go to the literature. You can read as much as you want. in between. But for that session, I'll talk further about you about that study, and those who agree to enter the study and sign to approve it, then we will go into that study. Okay, that's one. Any comment from the colleagues about that?
So we can do it in two ways, Doctor, if you want, either by video 10 minutes, or we can do it face to face. So we exposed and everybody answer. So there's
Yes,
two
yes.
ways we can do it, like physically or virtually.
So I will also have to rush an ethical approval through the ethics committee to enable this as appropriate. So that's good. Maybe I would like also to inform my colleagues that, we communicated with about the certificate. Most probably we will not get the certificate from AACME. We communicated with them. Dr. Yahya kindly wrote them, and it seems like they're not, they have so many.
So they want what they want exactly. They want me to pay them for 1 year, and I can do as many courses as I can. So I have to pay them lots of money. I think $5,000 they want. And then I can do as much courses as I want. Next year, they want 3,000 and then 2,000 and so on. So I can do, so there is two ways they do things, as annual or per course. But it seems per course, either they're telling the truth or not, I'm not sure, but it seems per course from UAE, many people are working with them, and they have limited, or they have a certain limit to how many people they should.
Yes. Now, but when they allow you to give a course for 5,000, say, they would need still from every candidate
Yes.
Maybe
Yes.
then for this reason, and also our communication with Egypt, the doctor, let's not name her here, from Egypt was really she didn't follow on our communications. At some stage, after waiting 1 week and writing and calling many times, she wrote me a message, but then at that time myself I stopped responding, because I worried clearly the way it communicates with her, that at the end when we send her the money we would not receive anything, especially with the restriction of MCA. So my recommendation now would be to continue the course with you, and if you can, as you said before, give us yourself a certificate from your
Yes.
side. Point is, doesn't change anything for me whether I'm having a certificate from you. It's after all a certificate of
No,
attendance.
it's a privilege system. So you can provide the privilege, like I'm sure you have a privilege committee in your hospital, like us, and then you can provide a privilege that.
I think
that you can
nobody
do.
from those who studied lung ultrasound had that luxury to have the teacher with you on so many sessions and talk as much as you want, ask as much as you want, like one-to-one, and then he comes to you, and then when we say 5 sessions become much more, and then cases prepared, and so that luxury, I think we will have. I would be confident. And now later on, if people approve to be part of that study, the aim of the study, to tell my colleagues, is that they will keep getting cases till they reach the level of skills. I might be the one slower among you. I don't know who will be slower. We don't look at who's slower, who's not slower, and it will be by numbers. So the point is that I will be confident that with certificate or without certificate, we would have the best education for lung ultrasound. Up to us to continue.
Dr. Shadid, I have the habit to collect everything. So I have a habit. I have like any baby, I collect all the progress notes because it's all types. So I collect it. I collect the presentation. I collect the pictures, the X-rays. So anything I collect, if you can see that. So I have almost 60 cases, 60 scenarios of lung ultrasound only. And I think I have 100 of heart POCUS.
Honestly, a kindness and gift to us that you're, I know every case myself, one case take me so long to prepare and to choose and things. So I know the investment you're putting in, and thank you very, very much.
No, you're most welcome. Once you get the habit to save everything and then it become a little bit easier and easier and easier, but it takes time. The scenario had to collect the information. It takes time, you know that, right? It's not easy. Yeah, it takes time.
It means to prepare.
It takes time.
Thank you very much. Thank you.
You're most welcome.
Next week I'll speak to my colleagues to explain
Sure.
to them.
And I'm happy in any way you want.
Analysis, and whoever approved to be part of it, I wouldn't force on anyone, but it's a benefit and a gain to anyone who'd like to be you know, so to do it. Thank you.
Thank you very much. Any question?
Thank you, Dr. Yahya.
Okay. Good night. Enjoy
Bye-bye.
the rest of night.
Bye-bye.
Assalamu
Thank
alaikum.
you. Bye. Alaikum salam. Thank you.
Just one question, Dr. Yeah, I don't know
Yeah,
whether
go
it
ahead.
is clear or not. Is it clear?
It's
Yeah, it
clear.
is
Yeah.
clear.
Yeah. For for the images for the lung hemorrhage, I think I'm seeing most of the hemorrhages happening near to the pleura, nothing deep in the lung. Is it the usual pattern or something different with the ultrasound images?
Well, the deep in the lung, you will always mostly like the airways. And if you want to see the deeper tissue, you have to do the curvilinear, because most of the linear you will see peripheral. So here it's not a matter of if you can see the lesion was diffused, so I'm sure there is inside the lung, but because the transducer is superficial and high frequency, so you can see it's 8 to 12, and it's a linear. So you can see that it is only picturing the superficial ones, but I'm sure there is deep involvement. If you want to see the highlight, as we said, you can use the curvilinear less frequency probe, such as 8, 7, or 6.
Okay.
Clear?
Thank you very much.
Okay,
Don't
sir.
use your time more than that. Thank you. Bye-bye.
Okay, take care. Bye-bye.